Welcome everyone to this live Healthy Living event. If you are letting gallbladder or hernia pain control your life, you don't have to. This is your first step toward relief. There are effective surgical solutions to hernia and gallbladder conditions that are better than ever before. Minimally invasive, quicker recovery, getting you back to the things you enjoy. Dr. John Donkersloot is going to discuss gallbladder issues and solutions, and Dr. Kristoffer Wong is taking on hernia and surgery options. What's great is they'll both answer your questions live. You can get your questions answered by submitting on Facebook or YouTube, or text me directly. Text, don't call, 248-935-2562. We start with Dr. John Donkersloot from Hurley's Comprehensive Surgical Group. Board certified in both surgical critical care and general surgery, Dr. Donkersloot completed a residency at St. Joseph Mercy Hospital and fellowships at both University of Michigan Health System and Hurley Medical Center. Doctor?
Hello, thank you. I'm here to talk a little bit about gallstones, which is a very common problem that if you take care of it early on, it's a pretty easy fix, but some people really have big issues if they let things go on too long. So as you can see there in the picture, there's a picture of your gallbladder. It's in the right upper side of your abdomen, right under your liver, and what it does is it helps you to digest fatty food. Everybody has a gallbladder, but around 10 to 15% of people have gallstones. So just to give you an idea, that's around 38 million Americans. And of those 38 million Americans, around 20% of people with gallstones will develop symptoms. So what are those symptoms? The most common thing that you hear when you're talking to somebody, or I hear, is they say, oh, I had a meal and I just developed this pain. And the pain usually starts around 30 minutes to an hour after eating a large meal, for some people usually containing fatty foods like salad dressing or a burger or a steak or pasta or something like that. And then what happens is the pain will either go away or it will stick around. And the issue with this pain is that if it starts to happen, usually it continues to happen. So if you have gallstones, around 70% of people will have recurrent pain episodes if the pain is due to the eating. Pain is the predominant symptom that people will develop, but they can also get bloating after eating, which is a bit more nonspecific. If a gallstone happens to get out of the gallbladder and lodge itself someplace, they can have a jaundice or a yellowing of the eyes, but that could be also due to some more serious things, which isn't the subject of this presentation, or they can just get indigestion. And for a lot of people, these symptoms occur and then they go away, and then they occur and they go away, and they write it off and they say, oh goodness, I might need to go to the emergency room once the pain gets there and sticks around, but that's a sign usually that the gallbladder has started to get an infection, and that's when we call it cholecystitis. Who gets gallstones? A lot of people in America, like I mentioned, but the predominant risk factors are if you're over the age of 40, if you're a woman and you're of a reproductive age, if you're pregnant, this is a common situation, somebody who's pregnant who has gallstones, or if you're using oral contraceptives, folks who are of Mexican American or Native American descent, rapid weight loss, and then also if you have a condition such as an anemia in which your blood cells get destroyed, and also people with diabetes. And the issue with folks with diabetes is sometimes the gallstones are a bit more silent until the attack gets really bad, and those are some of the people in whose gallbladders they're not just infected, they are nearly dead when we take them out, and that's a really difficult and dangerous operation. That's difficult for us. We can still do them, but it's something that we like to avoid. So let's say you're worried that you might have gallstone. You can say, well, how do I go about figuring out if I have them or not? And the good news is that testing for this is non-invasive, outpatient, and it just involves an ultrasound probe, which you can see right down there. And the good news is that it's accurate in diagnosing gallstones in greater than 90% of cases. You'll see on the screen there's gallstones that are there, and then the question is what do you do about it? So one thing that you may say is, well, I have gallstones. Should I get my gallbladder out right now? And the answer to that is no. The reason is that of people who do have gallstones and they're asymptomatic, a very low percentage of people do develop issues with the gallstones. And that's what all of those numbers are showing there. So if you say to yourself, I have gallstones, I need my gallbladder out, that's not necessarily the case, but the question is are you having symptoms? And that is the population of people in whom we'd say it's probably a good idea to get this checked out, and if it comes to be that you need your gallbladder out, that's what we would recommend, because something which we call biliary colic, which is the crampy pain which I described earlier, that's a lot easier of an issue to handle than somebody coming in with a gallbladder that's infected, or acute cholecystitis, or some of the worst problems that do happen from gallstone disease. Some of the people that we see with gallbladder disease, they come in with the first episode of pain, and that's understandable, but if it's somebody who has had pain at home for weeks or months, that's a situation that I think is avoidable. And one, you're less miserable if you get it out, but two, you don't develop the problems of gallbladder disease. So now that I've covered who gets it, how common it is, what the workup is like, what is the operation like for a gallbladder operation or a cholecystectomy? Generally, when we do these in the outpatient setting, which is, I think, the preferred way that this is handled, you find that you have gallstones, you're symptomatic, you see your primary care physician, or you make an appointment with us at the number below, and then we say, well, you should get your gallbladder out. What does that look like? So the surgery is done as an outpatient, which means that you show up, you generally leave the same day. The operation generally takes 1 to 2 hours long. So your time at the hospital is probably around 3 to 4 hours from beginning to end. When I say minimally invasive cholecystectomy, that's getting a bit into the technical details, which I won't do too much of. It's either laparoscopic or robotic. Both of those options are offered here, and as far as the patient experience, I think it's equivalent for this operation. But there's 4 small incisions that get made across your abdomen, and then what happens is we take the gallbladder out through these small little poke holes. The reason why it's good to do this on an elective basis is generally how difficult the operation is, how inflamed everything it is a lot less than if the gallbladder has gone bad and got infected or if it's dead. And this, if we do it on an outpatient basis for somebody who has symptomatic gallstones, it minimizes the risk of complications like a gallstone causing pancreatitis, and you can have really, really bad pancreatitis from gallstones, or having gallstones get lodged into the gallbladder or down into the plumbing of the liver, which means more procedures, longer hospital length of stay. And so conclusions, and here's a nice picture of the anatomy. You can see the gallbladder, which is right under the liver there, the drainage pipe from the liver called the bile duct. It goes into the small intestine there. I think the real takeaways for everybody is that if you have gallbladder symptoms, or if you're worried that you may have symptoms, see your primary care physician and go ahead and get an ultrasound. It's easy, it's quick, outpatient. And then if you have the symptoms, thinking about getting an appointment to get evaluated for getting your gallbladder removed, I think that'd be reasonable. But if it's just found that you have gallstones and you don't have any problems like I mentioned, it's perfectly safe to wait until symptoms do develop. So I think that concludes kind of what I have to say, and I'd be happy to take any and all questions.
If you have questions about gallbladder surgery, Dr. Donkersloot will answer them now. Text your question to 248-935-2562 or submit your question on Facebook or YouTube. So what you're saying is you could live forever with gallstones if they're not bothering you?
Yeah. The main thing is whether or not they're symptomatic or not. And so many people live long, happy, fulfilled, non-bothered lives with gallstones, and they never need an operation. And that's what I was mentioning is sometimes we get calls from the emergency room or something else, and they say, well, there's gallstones here. And we say, well, are they troubled by them? And if not, that's okay. But if they are, then or if there's a suspicion that you may be, then we say, well, it's not worth developing these problems. So then we recommend that the gallbladder gets taken out.
Jenny wants to know if she'll be on a special diet after having gallbladder removed.
And so that's a good question. The main function that I mentioned of the gallbladder is once it gets taken out, its main function is in digesting a fatty meal. So you eat something that has a lot of fat in it. Bile, which is stored by the gallbladder, helps to digest that, and sometimes a lot of fat is coming to your digestive tract all at once, and that's where the gallbladder really helps. The main issue that we see people having after their operation is sometimes if they have a fatty meal, they'll have diarrhea. And that's something that we counsel patients about, and we say, if you want to have a fatty meal, just know the location of the closest bathroom. But that's a problem that goes away within a couple of months, and the body's really quite good at adjusting its ability to digest fatty meals, even without a gallbladder. So we counsel them just to take caution about their diet with regards to fatty foods. But after 6 months or so, people generally don't have a problem, and they go back to life just like it was before having their gallbladder out.
There's gallbladder supplements that I've seen. Are those necessary, and does your body need extra help digesting? Or?
No, typically the gallbladder is sufficient to digest all the fats, and as far as supplements, we're talking about the typical thing that I think of is enzymes needed to help digest fatty foods. Those typically we don't prescribe after the gallbladder operation, just because the body is good enough at adjusting how to take care of things. So that's not something that I typically recommend. However, if somebody wants to try something like a supplement, I say go for it and see if it helps you, but that's not something that I typically talk to folks about.
So you go in, you get your gallbladder out, you leave the hospital that same day, then what's your downtime? How many days before you can return to work, exercise?
So we generally see our folks in clinic around 7 to 10 days after their operation, and at that visit we discuss their pathology report, in which we look at the findings from our pathologist here to make certain that there's nothing unexpected. But then what I typically tell patients is that for a minimally invasive operation, it's roughly 2 weeks or so of you can walk upstairs, get up and do things, but really kind of holding off on lifting anything heavier than a gallon of milk. And after that, it's increasing your activity level gradually for around 10 pounds a week, or until you start to develop more pain, until a month, and then you're back to full activities. So for folks, if you have a job in which you're not doing a ton of heavy activity, I say you can go back to your work and things like that whenever you feel comfortable doing so. But for folks who have a more active job in which you're needing to do heavy lifting or bending or things like that, it's a bit longer. So I'd say a good baseline is around 2 weeks.
In the incisions, one's in your belly button, so you really don't even see that.
Yeah.
The other ones, they're small and fade over time.
So the size of the incision, we put in little poke holes for the trocars, and those are 5 millimeters. So 2 of the incisions are 5 millimeters. Another one of the incisions is 12 millimeters, or less than half an inch. And so that's the general size of the incisions for the operation.
Okay, great. Thanks so much, Doctor.
Thank you.
Dr. Kristoffer Wong is now going to walk us through hernias and hernia surgery options. Dr. Wong is director of the Hurley Hernia Center of Excellence, board certified in both surgical critical care and general surgery. He completed his residency at St. John Providence Health System and fellowship at Wayne State University. If you have questions during his presentation, you can text them to 248-935-2562 or submit questions on Facebook or YouTube, wherever you are watching. Dr. Wong?
Thank you. So we're going to briefly go through a little bit what we offer here at Hurley Medical Center through the Hernia Center of Excellence, briefly define what hernias are, types of hernias that are commonly seen, dispel some myths about mesh. Everybody's always worried about mesh when they come in to see us at the Hurley Hernia Center, and what hernia techniques we offer in terms of repair through minimally invasive techniques, which often set us apart from a lot of other hospitals. The Hurley Hernia Center of Excellence right now, currently we have 4 surgeons, myself, Dr. Mercer, Dr. Sashwani, and Dr. Patrick Beer. The Hurley Hernia Center of Excellence, we offer new and innovative techniques for comprehensive care of large hernias and common hernias like inguinal hernias, groin hernias, and ventral hernias. We originally launched the Hurley Hernia Center of Excellence in April 2012, as distinguished through rigorous evaluation process. We specialize in all aspects of hernia repair and abdominal wall reconstruction. We practice quality clinical evidence-based medicine. We have research and innovation, as well as a lot of dialogue with our patients and private practice providers and referral-based physicians. So what is a hernia? A hernia is basically a hole in the abdominal wall or peritoneum. This sac comes through a weakness through the muscle layer that surrounds the abdominal wall, known as the fascia. And as you can see, there's multiple different picture types, both of an inguinal hernia or a ventral hernia, which is on the abdominal cavity. Hernia risks are more common in men, up to 27%, with a lifetime risk for women at 3%. There are about 5 million hernias repaired in the U.S., and of these, 750,000 of them actually require some type of treatment. There are many, many different types of hernias and many, many different causes of hernias. No patient is the same, unfortunately. So what are the signs and symptoms of a hernia? You may or may not have pain. This can sometimes be increased at the end of the day, especially after a long day on your feet. You may see a visible or palpable lump. You may go from an innie belly button to an outie belly button. Typically, fatty tissue enters first, and then over time there may be small intestines or large intestines, which you may see as like gurgling or air. This may be followed by an organ that gets stuck. So that may be the intestines or a larger solid organ like the liver or spleen or kidney, depending on the size of that hernia over time. Burning or gurgling or an aching sensation may occur at this bulge. You may notice some pain or discomfort, especially when bending over, coughing or lifting. All these increase your intra-abdominal pressure. Types of hernias based on location. So epigastric hernias occur in the upper abdomen, umbilical or the belly button. Inguinal, femoral, or groin hernias. Ventral hernias basically refer to anything on the anterior or the front of the abdominal cavity. Hiatal or paraesophageal hernias are actually inside the abdominal cavity, and this is when a portion of your stomach or esophagus goes up into your chest behind the heart. Sports hernias are ligament injuries, typically with flexion injuries, like in soccer players or football players. And then the last one are the large, giant hernias or loss of abdominal domain. So inguinal hernias are typically seen in the groin, typically more commonly associated with males with heavy lifting or constant lifting injuries. Typically may occur with just what patients usually associate with, doc, I went and I was helping somebody move and I went to lift, a refrigerator or a cabinet and I felt a pop, and next thing I knew I had pain down there in the groin. That's usually how inguinal hernias typically present. A lot of the times these start out that they were potentially congenital, meaning you were born with them, and then over time that area got weaker and then the hernia showed up, type of thing. Unfortunately, there's a risk for incarceration, which is basically where a portion of the bowel, both small intestines and large intestines, may get stuck, or worse, strangulation. Strangulation is when that blood supply to the bowel may get cut off, and then that becomes an emergency. These sometimes present as large hernias, where basically the patient comes in and they may have a large scrotal defect where it's basically in the groin, and the patient almost thinks like they have a third testicle because it's that large. Or they may be small, just a small bump or a small bulge that is causing some discomfort occasionally. Hiatal hernias. Hiatal hernias are, as I said, when a portion of the stomach bulges through the diaphragm into the chest. This may or may not produce reflux symptoms or acid reflux symptoms. It may or may not cause nausea or vomiting. And sometimes these reflux symptoms may compromise respiratory conditions like asthma and COPD. There's different types of hiatal hernias. And again, these are things similar to the gallbladder that just because you have them does not necessarily mean you need these fixed. If you have symptoms of unrelenting acid reflux, even though you take medication or issues swallowing or keeping food down, then it is definitely a time that you need to be seen by a surgeon for evaluation. Incisional hernias occur after an incision or a surgery. Unfortunately, any large incision or abdominal wall incision secondary to trauma or previous surgery, there carries a 30 to 35% risk of an incisional hernia after this midline abdominal incision. So unfortunately, that is something that we deal with and is very, very common for hernia surgery, is incisional hernias. So we see a lot of these, and not necessarily just because you had a large incision do you need a large incision to fix these hernias afterward, and that's what we can offer here at the Hurley Hernia Center of Excellence. Sports hernias, again, this is typically a ligament injury secondary to like adduction or flexion of the hip, in which it is against some type of resistance, and you could actually get a tear in that muscle ligament just medial to the pubic bone. This typically causes a lot of pain. It is not a hernia per se in terms of it causes a bulge or something to stick out. It's actually more related to pain and flexion of the hip. And a lot of the times you have to repair that ligament in order to relieve that pain. Ventral hernias or abdominal hernias or umbilical hernias, these are hernias that occur on the anterior abdominal wall, similar to incisional hernias. These can be congenital. Belly button hernias do often occur in pediatric patients up to the age of 5 as the abdominal wall starts to close. They can show up in overweight patients or postpartum patients after pregnancy, where a lot of patients come in and say, you know, doctor, I used to have an innie belly button and now I have an outie belly button. And typically at that time, there's just a small amount of intra-abdominal fat that starts to break through the anterior abdominal wall between the muscles. Other ventral hernias or hernias elsewhere can happen up to 10 to 30%. These can typically occur anywhere like in the epigastric region or above the belly button or below the belly button, associated with what's known as a rectus diastasis. A rectus diastasis is actually a thinning of the rectus abdominis muscles or your six-pack muscles that can occur with increase in weight or, again, after pregnancy. Other things that increase the chance of ventral hernias happening are medical conditions like diabetes, obesity, patients that smoke, patients that are on long-term steroids or malnourished, previous abdominal skin infections, or patients that have some type of collagen defect like Marfan syndrome. And then the last hernia that we see are these large ventral hernias, these loss of abdominal wall domains, patients that have unfortunately had multiple surgeries or multiple hernia surgeries, and they're coming in basically with complete loss of their abdominal domain. And this is what we kind of pride ourselves on being able to fix here at the Hernia Center of Excellence. We see a lot of these patients that are referred from outside hospitals because these are hernias that we typically take a lot of pride in fixing with the techniques that we have here and offering a lot of options to these patients. Now, unfortunately, a lot of these patients don't necessarily, wake up with six packs again, but again, to not have to have hernia surgery down the line, that's the goal for a lot of us here at the Hernia Center of Excellence. So the next thing we're going to talk about is mesh hernia repair. Again, mesh is something that we use as hernia surgeons to fix a lot of hernias. It does increase it does decrease the risk of recurrence, which again is the main goal, especially for things like inguinal hernias and ventral hernias that have recurred. It almost completely decreases the chance of recurrence by half, and almost down to less than 5% for inguinal hernias. So mesh is a tool that is used a lot by the hernia surgeons here. Again, a lot of the mesh is put in positions where it's away from the bowel, away from the bladder and the nerves, in a position where it's not going to typically erode into things like the bladder or the vaginal wall and things like that you may see on a lot of late night television commercials about, do you have hernia mesh, contact this number type of thing. Mesh is typically something that is inert. It does not typically cause a reaction inside the abdominal cavity and or within the patient. Now, there are other types of mesh that we can potentially use. Not every mesh is there forever. There are a lot of other options, biologic mesh and biosynthetic mesh, that are also used in certain situations for patients. And again, this is something that here at the Hernia Center, we pride ourselves on being able to take each patient that we have and find the right option for them. Now, that is a patient-by-patient basis, and that's something that we try to offer every patient. And not necessarily is mesh bad. Mesh does not always cause pain, and mesh does not always cause a recurrence of hernias coming back. All right? The other thing that we do offer here at the Hernia Center is a tissue-based repair on patients that do qualify. We pride ourselves on, again, there are non-mesh repairs that we can perform, and some of those patients that receive those, again, it's a discussion with the surgeon on whether or not they qualify for those options. Goals of hernia surgery and goals of what we pride ourselves here at the Hernia Center of Excellence are a quick return to work, school, normal activities. We want to limit postoperative pain, which unfortunately is something very commonly associated with large hernia surgery. We want to decrease the risk of a recurrence and again decrease the risk of postoperative infection. So what does Hurley offer? We offer a variety of approaches. Minimally invasive techniques, as originally said by Dr. Donkersloot, we offer both laparoscopic and robotic approaches to hernia repair. That allows us to do large abdominal hernias with small incisions. You may have a large abdominal hernia that can be fixed with 6 small incisions, and we're putting in a piece of mesh that may be anywhere from 35 to 40 centimeters long and wide, which is a large mesh just through small incisions. All right. Some patients do require open surgery secondary to previous hernia repairs, scar tissue and things like that, and we offer a variety of open techniques, both tissue-based and mesh-based repairs. But a lot of these techniques we utilize typically are geared towards getting you back to your activity as soon as possible and decreasing the chance of recurrence and infection. Here at the Hurley Hernia Center, we also offer a comprehensive approach to the hernia repair. It's a team approach. A lot of the staff that we utilize have been here for a long time. There's a lot of discussion on terms of what the best hernia repair is for you. And not every hernia repair is the same. Not every patient is the same, and not every hernia is the same. So that is our goal, is to offer the right hernia surgery for you. This is the robotic console. As you can see, for the minimally invasive surgeons, we use this technique a lot. The console's in the room, and the robot is being controlled by the surgeon, which allows us better visualization, ability to work in smaller areas with more finer precision. It's almost like we're inside the abdominal cavity with our hands, without the big incisions. Lots and lots of studies have been performed over the last 5 to 10 years about the utilization of robotic surgery and hernia surgery. Those studies have shown decrease in utilization of pain medication postoperatively, decrease in recurrence, decrease in infection, and decrease in hospital length of stay postoperatively. So again, this is something we pride ourselves in and being able to offer at the Hurley Hernia Center of Excellence. So why is minimally invasive surgery used? Again, as I kind of went over, smaller incisions, fewer complications, shorter hospital stay, reduced recovery time, increased mesh coverage, which prevents recurrence, and decreased rates of infection. Thank you very much.
Okay, last chance to get those questions in by texting 248-935-2562 or asking on Facebook or YouTube. Patricia says that she's had 2 different hernia surgeries and is now experiencing pain again and wondering if it's possible that they come back. It sounds like exactly what you were talking about with the large ventral hernia.
Yeah, and again, like a lot of the times, recurrence can be just that nagging sensation that there may be something there, that you may or may not actually feel a bulge. So again, if you're worried about a recurrence, I would definitely recommend seeing your primary care doctor or making an appointment at the Hurley Hernia Center. And we can talk about options for imaging, which usually is a CAT scan to identify if there's evidence of recurrence, and then what the plan is from there.
This patient said that they were just referred to Hurley by a surgeon in Owasso, and that the surgeon said after CT scans in upper GI, her entire stomach is in the chest. Can you explain? Is
so
that
this
common, or?
So this is a large hiatal hernia or paraesophageal hernia, where a large amount of the stomach goes up into the chest. Again, this is something that we can and do repair here at Hurley. We get a large amount of referrals from outside hospitals that are uncomfortable doing some of these surgical procedures just due to the size and the possible postoperative complications. We do a lot of these, again, minimally invasively robotically, which again gives us better visualization and the ability to reduce the stomach back into the abdominal cavity and close that diaphragmatic / hiatal hernia. And then offer some other techniques to make sure that the recurrence rate is lower.
Maya wants to know if there's any way you can just wear a belt or something to hold the hernia in.
So again, hernia belts or groin hernia belts or abdominal binders for ventral hernias, that it may help the symptoms in terms of like it preventing it from bulging out. But again, just by wearing that belt, it's kind of uncommon that it always is going to be in the right position. So what may actually happen is that hernia still may bulge out, and that hernia belt may kind of cause more problems than it is helping in terms of keeping everything in. Similar to gallbladder disease or a lot of other medical problems, the sooner you kind of get your hernia looked at, even if you're not having a lot of pain, a lot of symptoms or things like that, the recovery is always less. A small hernia that takes, that you notice over a couple months is definitely going to heal faster after repair than somebody who's waited 5, 6, 7 years to get their hernia fixed because it didn't really bother them.
Coughing constantly from COVID, this person noticed their hernia had gotten larger and is sticking out when they wear a fitted shirt. They want to know if coughing or even constipation makes hernias worse.
Yes, so anything that increases your intra-abdominal pressure is definitely going to put more stress and strain on that hernia. Unfortunately, I always tell patients I don't have a crystal ball in the office, so I can't tell them when the hernia is going to get bigger. It may happen tomorrow, it may happen weeks or months or years from when they see me in the office. So things like coughing, things like gaining weight. Patients who have gained weight over time may notice that the hernia may get bigger. And again, all those things can increase the size of the hernia. Same thing goes with post-operative recurrence of the hernia. So after we fix it, whether or not the hernia comes back, that has to do with a lot of, again, weight gain. Patients, female patients, and we have a lot of conversations in the office about pregnancy and planning on getting pregnant after hernia surgery, because again, that's something that can increase the chance of recurrence of the hernia post-operatively.
Can females have groin hernias?
Yes, so females can have inguinal hernias, both femoral and inguinal hernias. They're more common in males, but they do and can occur in females. Again, unfortunately, they don't have testicles, the scrotum down there, so it's not as easy to diagnose, but again, symptoms can be similar, and they still may have bulging and pain and things like that they may notice down in the groin area.
Can you talk a little bit about recovery time? I've gotten several questions about small umbilica hernia, whether you have to take stool softeners or for how long, and if you are doing heavy lifting at work, how long. So
again, a lot of the hernia surgery, depending on the type of hernia surgery you have, the size of the hernia, and what you do for a living, those are all things that we take into account when you see us at the clinic. Now, not every patient, not every job is the same, not every hernia defect is the same type of thing. Again, similar to Dr. Donkersloot and the gallbladder, most patients go home either the same day or the next day, depending on the size of the hernia. They may be in the hospital for 3 to 5 days if it's a larger abdominal wall reconstruction, even minimally invasively. Patients are restricted to not lifting more than a gallon of milk, typically after any of the hernia surgeries, both groin, umbilical, ventral hernias, for at least a week to 2 weeks, and then slowly increasing their activity in terms of walking. They're doing stairs, which is fine, and then slowly increasing their activity kind of at that 2-week mark. And usually by then, most patients, they're not requiring pain medication, they're not requiring any other adjustment to their daily activities. And then we have long discussions in the office about what the plan is for work. Because again, as a hernia surgeon, we understand, that's your job, you have to go back to work. We never want to put you in a situation where you're going to hurt yourself. The chance of recurrence of you lifting and tearing the mesh or breaking through our hernia repair is low. A lot of the times what we see with patients is they lift incorrectly to compensate for that soreness or the abdominal pain they may have after surgery, and they cause more issues with their back or, injuring themselves at work trying to do something they probably before didn't really think much about. So a lot of that is discussion with the patient and getting them back when they feel comfortable going back to work without restrictions.
And what about age? Is there any age where someone's too old for this?
There's not an age limit. Again, as long as you're cleared medically with your past medical history of heart problems, lung problems, all those things, we can do surgery on you. Again, especially if they're symptomatic. Now, being seen in the office by a surgeon, that can be a discussion that we can certainly have on whether or not that hernia is small and with the other medical comorbidities is worth taking the risk to fix, or if it's something that is causing a lot of pain and symptoms and fixing it now as opposed to waiting till something bad happens might be more prudent.
Thank you so much. With Hurley, you can take comfort knowing minimally invasive procedures prioritize your comfort and reduce recovery time. Make an appointment by calling 810-262-6555 or heading to hurleymc.com. We thank you for joining us and hope this one-on-one time with the doctors helps you make the best decision for your surgery. And of course, as always, we thank our broadcast partners, Mid-Michigan Now. Have a great day.